So would you like to continue, or we stop in this point? What do you like? Because would you like?
Oh, sorry.
Okay, everyone want to continue? Okay, we make voting for 30 seconds. I see that. Yeah. Okay. Okay. So let's go and continue. Yes. Okay. Also, I want to ask you about maybe Monday we can do another session, but maybe it's not very long like this one. But do you agree with Monday? Monday, 9 o'clock, the same time? Do you agree on Monday? Everyone agree? Okay. I try to make some, we can make condensed lecture because the people who have the exam in, the colleagues who have exam in 15 August, right? Yes, and maybe some also have after, but who have this exam, okay, we can. Let's continue. Okay, so there we have this appearance. Then you will go and mention that what is the differential? Myths, nice. When you have background of healthy one, so myths until proved otherwise. Myths. When you have cirrhosis patient, it is until proved otherwise. Okay. When you have healthy background of liver, it is myths until proved otherwise. When you have, this is the most common, yeah. When you have like cirrhosis background, as this case, it is, yes, HCC until proved otherwise. So in this case, myths, okay. So what the differential, as you mentioned, it will be multifocal cholangio and multifocal HCC, even if it is not cirrhotic, as we mentioned before, and lymphoma, yes. So lymphoma and multifocal cholangio, multifocal HCC. But cholangio, what you will search for the biliary dilatation and the capsular retraction, okay? Maybe we can have case after. So nice. So this is multifocal lesions. This is the differential diagnosis. So the key point, search for cirrhosis. Is it present or not? Okay. When you find thickening, try to localize it, which site it is. I think now we are talking about the colon, yes. So we are in the cecum. So search if there is any involvement of the terminal ileum or not. Yeah. Then also the age of the patient can help you. So typhlitis is good option. What is typhlitis? It is, what is typhlitis? Because maybe someone, yeah, it takes inflammation, take the cecum, right colon, and the terminal ileum. Yes, neutropenic colitis, perfect. So why neutropenic? So you search for history of leukemia or lymphoma or treatment with chemotherapy. So have this toxicity and make typhlitis, one of the good cases, yes. And then if you don't have this history, search for other causes. What other causes? It will be TB and Crohn's and appendicitis, which is more common, appendicitis in the practice even, and other like diverticulitis. Ischemic colitis could be, but it is not very typical. And other tumors. What good tumor could make such appearance? It can colon carcinoma, lymphoma, and metastasis. Okay. So this is what is called typhlitis, and already we mentioned the differential diagnosis. Yeah, short case maybe, or maybe long case. So search for the landmark to know where is it. Yeah. So if we think that maybe, yes, this is the site of the, this is pseudoaneurysm, perfect. Pseudoaneurysm, and this place is the site of the, beside the duodenum, it should be the site of the gastroduodenal artery. Yes, gastroduodenal artery, perfect, Marwa. And then think about pancreatitis, and when you see this appearance, you can think about pseudocyst. So we mentioned it before, pseudocyst and make pseudoaneurysm, and in this case was rupture. Here there is no rupture, but maybe. And this patient can, the intervention can help him if he do like coiling, right? Okay. So this is what's called gastroduodenal artery syndrome, complication of pancreatitis. And we mentioned already that can happen pseudoaneurysm, splenic or GDA, fluid collections, abscesses, necrosis, hemorrhage, thrombosis. Okay. Maybe I'm not sure, because this is just one image, so we are not really sure if there is any thrombosis. But what I see that there is pseudoaneurysm. There is aneurysmal dilatation in GDA, and this is the pseudocyst from the. She make. I think it make the complication. So, okay. I'm not sure. Maybe I saw it, but I'm not sure that this may be thrombosis in this case. Maybe I don't have the complete case. So okay. GDA. Okay. What do you think about this one? It's much easy. Yeah. It comes to you if you practice ultrasound, and yeah, you can think about cholecystitis. Yeah. Perforation, why you mention perforation? If there is, it's good to mention that you will search for free air. If you find the free air, you will think that it is, yeah, fluid maybe. Yes, the fluid, nice. So the fluid outside, then you think about cholecystitis of with perforation, and also the wall defect. Okay, maybe here, maybe here. So cholecystitis with perforated gallbladder, nice. Okay, acute cholecystitis, there is gallstones, thickness of the wall, hollow, and stranding in the pericholecystic fat, as we have here. Okay, and there is air in the lumen or wall if it is emphysematous. Yes. The severe form of cholecystitis, this is what's called the gangrenous cholecystitis. They like it in the X-ray, and they show you like this. Any emphysematous, either colitis, as we show you before, or cholecystitis, or cystitis, emphysematous in the urinary bladder. Okay, so this one, when we did CT, you can see clearly the air in the, yes, this one what's called gangrenous cholecystitis, and this one acalculous cholecystitis. Let's go for this one. Yeah, this is much easy now. No, I bad, no. We go to the rule of when you find the cirrhosis liver, so any lesion in the liver, it will be HCC until proved otherwise. So when you find cirrhotic liver, which is advanced cirrhosis here, so what happened here? Take arterial enhancement and wash out in the portal phase. So it is the typical appearance of HCC in the triphasic. We don't just have dual phasic, but in triphasic it is the typical appearance. Make wash out. Okay. I think this is partial volume probably. So neglect it in this selected image. Okay. So HCC, don't forget the triad: cirrhosis, splenomegaly, portal hypertension, and if you will suggest something, suggest to correlate with alpha fetoprotein, okay? And don't forget to look on the portal vein, hepatic veins, and IBC. When you find this appearance, yeah, what do you think? Yeah, you find the low signal of the liver, right? Okay, so it is like the low signal, and if you suggest what you will do, which sequence is very helpful in this case, it will be the
T1 out phase.
T1 out of phase, perfect. Nice, and T2 star also, nice. So T1 out of phase. Okay, so what do you think it could be, primary or secondary? What the difference? Primary, do you like it in the MCQ questions? Which one is primary? Yeah, when it is in the spleen, it is SS. When it is a spleen, it is secondary. Yeah, when it involves the spleen, so it is secondary, right? When you find the low signal, it takes liver and spleen, but the spleen, because in the primary type, the spleen is not involved. Perfect. You agree? Everyone agree? Okay. So again, HSC with liver cirrhosis and with tumor thrombosis. So if I ask you how to differentiate between tumoral thrombosis and the thrombosis without tumor or blunt thrombus, the enhancement. So the
Thrombus enhanced.
perfect. So the tumor which have tumor, so the thrombus which have tumor, it will enhance and the follow the tumor. So it will be arterial enhancing and wash out in the perfect. Yes, much cases. Try to find your landmarks. I know that selected image, but you can try to, yeah.
Mucinous.
Where is this? No.
Mucinous cyst.
Mucinous, but you mean that it could be pancreas, right?
Yes.
So let's
Mucinous
agree that it's pancreas, then we can see what it is. So yeah, I agree with you that it's pancreas. So if it's pancreatic, we mentioned cyst, so go for differential of cyst, pseudocyst, or yeah. And the types of pseudocyst, we can say that the entity of pseudocyst, wall of necrosis, if it is more than 4 weeks. If it is necrotizing and more than 4 weeks, then you can call it wall of necrosis. Why you mentioned that it is necrotizing? Because you cannot see the parenchyma of the pancreas in the post-contrast phase, right? Yeah. So if there is necrosis, then you are going with, yeah, replacing the parenchyma with this necrosis. So this is what's called acute pancreatitis. And I suggest you to read this article in Radiology Assistant about how to differentiate between the pseudocyst and wall of necrosis. And the time is very important, between 1 month, less than 1 month, or more than 1 month, and so on. And how differentiate acute from other stages of pancreatitis. Okay. So abscess or pseudocyst, they say that if you find the gas, then there is a sign of infection, then think about abscess. Okay. Pseudocyst, we mentioned rupture, bleeding, infection, pseudo. Yeah. I know, Marwa, I know. This is just selected image, so I agree with you that we don't have pancreatic phase. Okay. Let's go to the next.
Adenomyosis.
Yeah, so you mentioned that it could be polyps. Perfect. So you will describe that there is polyposis syndrome. Then, as you see, this is double contrast enema, right? And there is multiple filling defects. So this filling defect should be representing like a polyposis, right? So when you go to polyposis, then search for other types of polyposis. So you know, remember, if we find this, so if I tell you that this patient did colectomy and he have like, yes, why you mentioned Ines, why you mentioned, yeah, because multiple lesion in the abdomen probably is desmoid. So this desmoid with polyposis represents something called Gardner, perfect, nice, Naveen and Ines, Gardner syndrome. So this is what is called Gardner syndrome. It is something autosomal dominant, sure that you have polyps, and here the risk of colon cancer is 100%. So that's why this patient should have prophylactic colectomy, okay? So if he gave you like head neck case, you will find sinus osteomas. If he give you maybe brain case or head and neck, you find the head dermoid cysts, and finally you'll find abdominal desmoid. This is what's called Gardner syndrome. And in the textbook, you will find like many types of polyposis. As you remember, familial polyposis, Gardner, Turcot, which is have something in the neuro, central nervous system tumors with glioma and medulloblastomas, and other types like Lynch syndrome, which have cancer in everywhere, Bitzjigger, which is hamartomatous polyp, and Cowden, someone mentioned Cowden also, okay? And Canada, which is the only one which don't have cancer, maybe, yes, if I remember it. Angiofonile polyps, hamartomatous, and yes, okay. So this Canada, which is the only one which doesn't have cancer, okay. So try to just memorize them, but Gardner, one of the commonest, and Turcot also, I think, you have cases because it's linked with neuro. So they will show you medulloblastoma, and sure that he will be young or pediatric age group, so it's easy for you to know it, okay? Yes? No, but yeah, maybe that there is obstruction. You mean that there is obstruction, and good that you think about pneumoperitoneum, that you will search for any regular sign. Okay, nice. But there is small bowel obstruction. Okay, and you will search about the cause of small bowel obstruction. You agree? Let's have a look and try to find the cause of the, yeah? Yeah, lipoma. And what happened here that it is intussusception. Perfect. Yes, Marwa. So go back and see how it is. It's not very easy, but at least you can suggest that small bowel obstruction. And I agree with you that most important to mention as negative that there is free air or not free air. And after that, you will sure that the surgeon ask you to do CT. And if you did CT, you will find the mechanical cause here, which make intussusception. So the tumors like lipoma, leiomyomas, and GIST and adenoma can make intussusceptions. Sometimes it can happen also with malignant tumors, as we mentioned also Meckel's. Okay? So this is what's called intussusception, yes. The pediatric have the major portion of this intussusception, But in the adult, search for lead point, which is here in this case, it is like lipoma. Okay? Can also be related to underlying disease like celiac with the scleroderma. This is in barium, and in the ultrasound, we have pseudo kidney sign and target sign, and donut sign, who like donuts. Okay? So, what do you think about this? Again, in barium terms, what you will. Okay. Yeah. Is it malignant stricture or benign stricture? I think it is going with to be malignant, even ulceration. Yes. Ulceration in the posterior wall. Yeah. And it is going with, yeah. They mentioned that is going with something called Karman meniscus sign, yes. Here, yeah. So they mentioned that it is going with esophageal carcinoma. Okay, the most common in the esophageal cancer, it will be squamous cell carcinoma, they like in MCQ, and risk factor include everything, especially smoking. And there is for radiological pattern is either annular, polypoidal, infiltrative, and ulcerative. This is what we mentioned before, that it can be differential in varicoid in varices, but to be honest, is not very similar. But we mentioned that is good. We mentioned in the varicoid varices, yes, varicoid carcinoma. This is very important differential about large intramural esophageal tumor. Fibrovascular polyp, which is the rare case, but we mentioned it also. Spindle cell carcinoma, squamous cell carcinoma. Okay? And also some hematogenous myths from Kaposi sarcoma and melanoma and renal cell. When you find odd metastasis, search for renal cell or melanoma. And it's a hypervascular metastasis, okay? So this is what is called fibrovascular polyp, which is not a common entity. It's very, very rare entity. Okay. What about this one?
Esophageal Leiomyoma.
Why? Yeah, why leiomyoma? Yes, but why? Perfect. Why? You can see this mucosa here, and it is elevated, right? Elevated mucosa, right? As you see here. So that means that the wall itself, it have the lesion, and the mucosa, it is not affected. But when it is
angle with the wall is obtuse.
Yeah, and also the angle, yes. But when it is, yeah, when the angle also is obtuse, perfect. And when it is like carcinoma, you will see this mucosa is entrapted, right? And also you will see like shaggy appearance, irregular pattern. So this is how the benign, smoothly, yes, appearance is looking, right? If you did CT, it is more easier that you will find that there is thickening of the esophagus, right? There is circumferential thickening. So this is what is called esophageal leiomyoma. Smooth, soft tissue, intramural mass. Sometimes it can have calcification, and it can have exophytic, like GIST. Exophytic. What is your differential? Will be lymphoma, sure, but okay. And also fibroma, neuroma, neurofibroma, lipoma. Perfect.
هذا mesenchymal tumor.
Nermin, yes, okay. So sorry, they asked to mute everyone. Can sorry. Okay, can everyone mute himself, please? Okay. And so I will, yes, okay. Duplication cyst, enteric duplication cyst, fibroma, neuroma, neurofibroma. Okay. Let's shift to next. So this is the esophageal leiomyoma, which is benign tumor of the esophagus, the most common one. And they have many appearance of esophageal leiomyomas. So what do you think about this? This is double contrast enema. Yes? Why? Again, why? Yeah? Yeah, it's submucosal. Why submucosal lesion again? Look in the mucosa here. Yeah, it is elevated and it is not interrupted, right? So when it is not interrupted, the mucosa is intact, so it is submucosal lesion. Then think about, again, our differential. So one of the most important differential in this case will be GIST, perfect, yes. And leiomyoma again, and so on, yes. But this one, it is a GIST lesion, yes. And he show, if he show you this appearance, then it is more easier to know that is exophytic tumor, which have the major part outside, so it is GIST tumor. Nice? Okay? Yes. If it have intramural portion like this one, it can make ulceration and bleeding, and this patient can present with hematemesis, yes, clinically. So this is what's called gastrointestinal stromal tumor. It comes submucosal, subserosal, exophytic, and the complication, ulceration, and GI bleeding. Let's have a look in this case, and I see that perforated, yeah. There's perforation, and search for the cause of perforation. And when you see the contrast here, and you see the contrast is reaching the, yeah, this one, Marwa, is like hydropneumoperitoneum. Hydropneumoperitoneum. And when you find the contrast here, search for the contrast where it come from. So you can see that the stomach here, and probably the air here. So this is gastric ulcer, and this is perforated. So thickening in the stomach with gastric ulcer, free air. So you are going to critical, very critical condition, very, very emergency case. Okay. Combination of gastric with thickening, free air. Okay. Again, similar to previous case, we have this one in the esophagus. This one coming a filling defect, but it is in the duodenum, yes, in the duodenum. So it will be differential, sure. One of the most important to mention that it is duodenal. Duodenal. What make filling defect when it is, yeah, polyp, perfect, yes, polyp. So polyp and adenoma, sure that you can put it. And again, you can leiomyoma, GIST, metastasis, maybe ectopic, pancreatic cyst, yes, adenocarcinoma. But the most important to put at the top of differential, polyp or adenoma, as we mentioned before in the esophagus, right? Yes. This is what? Duodenal polyp, solitary duodenal mass. So this is the differential. When you find duodenal nodular mucosa, it will be ectopic gastric, Brunner gland hyperplasia, as you mentioned. Okay. Nodular lymphoid hyperplasia, villus adenoma, varices, edema, hematoma, duodenitis. This is what is called Brunner gland hyperplasia. And this is what is called nodular lymphoid hyperplasia, which have many nodules. And yeah, let's have this case. What this important case for long and short. This is jejunum, and I agree with you that the colon maybe it is not in location, but yeah. One of the important differential to mention that it could be internal hernia. Asil, welcome back. I just see your name now. Okay, Asil. So internal hernia, one of the good differential. Why? Because you can imagine how the small bowel look like here. Why it is confined in this area? It is like a sac, right? Even this sac, it is like displacing the other bowels. Yeah. So when he did CT, you will find like this type of internal hernia in abnormal position, yes. And it is behind the stomach. And the most important to follow the vessels. I cannot show you the other image, but I can see that the image here, the mesenteric vessels should be engorged, mesenteric vessels. Then it is typical for internal hernia. Sure that if you have multiple pictures and to scroll through the other image, it will help you to reach this. But this sac appearance and the common location behind the stomach in paraduodenal, left paraduodenal region. So this is the most common type, paraduodenal hernia. So there are other types like paracecal or lesser sac or transmesenteric. If you write internal hernias in radiographics, and you will find like very nice paper in radiographics, which is very nice if you want to look for the other types of internal hernias, and they have very useful images. I suggest you to, if you have time, to just look in this. I write it in the chat. So yeah, the location is very important. That there is, it is the left one. It is extend in the fossa of Landerser, with jejunal lobes in the left upper outer quadrant, like here. Okay. And the right one, it is behind the hepatic flexure. And as you mentioned, yeah, foramen of what? Yes, I agree. The complication, sure, it will be obstruction, ischemia. Okay, treatment will be surgical, CT for diagnosis or barium follow-through, or maybe CT enterography, maybe. So this one is the right paraduodenal hernia, which is behind the hepatic flexure and extends through the fossa of Waldeyer. Yes. The most important to look, as I mentioned to you again, look for the vessels. This is the key. The superior mesenteric artery, the superior mesenteric vessels. Sure that in the selected image it will be a bit difficult, but search for it. You will find the key. In the exam, they like ischemic colitis. Don't forget this. The long case, it can come to you as ischemic colitis. So don't forget. Look first of all in the superior mesenteric artery, okay, and the branches. It can come even the branches. Don't forget it, okay? When you find the pediatric case, search for the pediatric age group complications or disease. Yeah, and one of the most important thing that you find this inguinal hernia. Even sometimes they, even sometimes they show you that there is obstruction up, and they wait from you to see the hernial orifices. Okay, sorry again. I want just to mention this, yeah. To show you the hernial orifices sites. And in the FRCR, they like much this case type of cases. Just from the X-ray, you should have the diagnosis because it's pediatric age group, so you shouldn't expose him to radiation. And also in the ADIR can come to you is short question. And they mentioned that there is, as you know, direct and indirect type. Sure that everyone see this before, but search for the small bowel obstruction, okay? Sometimes is critical. I think that there is one case in the long question, I think it come, and it was like this. It was a small bowel obstruction and was inguinal hernia down. And if you don't scroll down, you will not find the cause. And really it's critical. And in the exam, they show you like multiple sequences and multiple phases and multiple series. So you should be quick in your scrolling, okay? Quick and accurate. This case, maybe in the barium really is difficult. I don't know if you can see anything, but imagine that the pathology is here. You can imagine this. In the CT, maybe it is more easier. Yeah. We mentioned some rules. When you find liver cirrhosis, you mention HC. When you don't find liver cirrhosis in liver, you mention MITS. So when you find right iliac fossa stranding, this is appendicitis. Perfect. So when you find right iliac fossa stranding, fat stranding, smudging, misty, fat, anything, dirty fat, so you are going with appendicitis. So the most important, the most common, it is the appendicitis. So search for appendicitis and search for the feculith, yes, appendiculith, the calcified or the calcified, appendiculith, yes, like this one. This is the appendicitis. So put something in your rules that right iliac fossa pain with fat stranding, and search for appendicitis at the most common one, okay? Then you can search for other, you don't find the appendix, typical appendicitis. So what you find here, dilated thickened appendix, the measurement is important to mention that it is more than 6 millimeter with wall enhancement, some appendicitis fat stranding, and the complication. And one of the complication again, it is 3-air perforation, and again abscess formation, and so on, okay? In the barium, I didn't think that is easy. They mentioned that there is periappendiceal or appendix pericecal abscess, and this abscess make this mass effect. So this should be the cecum, and this is the ileum, okay? And the mass effect, it is in the ileum. It is not easy, but I think in the real practice, they order like CT, yes. Okay? It's clear? Okay. I think we should stop for this. Thank you, and we will try to continue on Monday, inshallah. Have a nice Eid holiday, and I think today everyone is busy with the celebrating and eating much meat, and I hope that everyone is enjoying. MSK, yeah, maybe I will try to find one session to make discussion also for this case. Hope everyone enjoying, and have a good night.